Okay, hello everyone, and welcome to the 14th session of the online Optom learning series. Thank you all for attending all the sessions, and those who have joined us today, thank you for joining us. So, without further ado, let me introduce to you our speaker for today. We have Optom Sakina Mussaji. She's an optometrist. She finished her bachelor's of optometry from the Bharatiya Vidyapeeth University in Pune, India, and she further went on to a specialization in a fellowship in pediatric optometry at the Shankara Eye Hospital or Shankar Netralaya, Chennai. Currently, she is working as a consultant optometrist at the Mombasa Eye Hospital in Kenya. And today she will share her thoughts and views about conducting a pediatric eye examinations and share with us her experience in pediatric examination. So please welcome her, and we would allow her to talk now. Sakina, you can start now.
So thank you for that warm welcome and introduction, sir. And thank you everyone for joining in, and a very good morning to all of you. So taking no further delay, let's see how should the approach to pediatric eye examination should be. Okay, so when we think about a pediatric patient, like when the word pediatric comes into our heads, this is what exactly what we think: a crying baby who is very uncooperative. But our work is to turn this crying baby into a smiling baby, right? So let's hope that by the end of the exam of the presentation, I can answer that question that how is that we can make that crying baby a smiling baby. So in the entire presentation, this is what we are going to talk about: how we are approaching a pediatric patient, what the history taking looks like, step-by-step evaluation in pediatric patients, what the visual milestones are, and what clinical pearls we should take into consideration. Okay, so when we have a pediatric patient presenting to us in our clinic or in our OPDs, this is what we should always keep in mind. We should always be positive. So whatever the situation may be, or whatever condition which we are going to see, we don't have to lose our have to lose our cool. We have to stay calm and stay positive throughout. We have to keep a smile on our face so that even the child feels positive, and it makes them motivated towards us, making it easy for them to connect with us. Psychologically, we have to make sure that the child is not ready for an examination. They are scared with the name of a hospital. So like, what would we do when a normal patient would walk in? We would just introduce ourselves, we will greet them and just directly ask what the problem they are having. But that is not the approach which we take in a pediatric patient. We have to start with a good conversation. Start like, what did you have for breakfast? Or if it's a post lunch session, ask what did you have for lunch. Compliment on what they are wearing. Like, if you can connect with them with asking them, oh wow, you want red, even red is my favorite color. Or you can talk about the cartoons they like. Suppose they are wearing a Superman t-shirt or a Doraemon t-shirt, anything. Just talk to them. Oh, is Superman your best character? Even mine. So you just try to connect with the child. Try to make it a regular day for the child. Make the child feel that he's just meeting someone new in his life. Okay, then once the situation is comfortable, a good rapport is created with the kid, then we can slowly move into the tests which we are going to do. And one point to always remember is we have to be ready to improvise, because a normal eye examination protocol may not work with these kids. So this is a part which is very important for all our patients, be it pediatric, be it geriatric, be it anyone who is walking into a patient, the history. So what I'm just going to tell you about is what's different we ask in a pediatric patient from the normal history which we usually take. So first we have to ask about the purpose, why they have come in, and the present complaints, because this will give you a tentative diagnosis of what we are going to see, handle with that specific baby or child. So we have to ask them that. In present complaints, we have to ask them if the parents are noticing any squint, because sometimes they wouldn't tell you in front that I have my child has a squint, or they will try to hide the fact. So we have to ask them that, do you notice any squint at any time? We have to ask about the abnormal head postures the baby keeps during regular activities. So that are the things we have to ask differently from what we would usually ask some patient. So moving into the ocular history, uh, normally we would ask about the glasses and the contact lenses, any diseases or any surgeries. But what different would be here is, first we have to ask about the compliance. We have to ask about the glasses compliance. Is the child wearing them? Is he peeping over the glasses? Or does he prefer wearing them, or does he not prefer wearing them? So that is something different which you would ask. Something else we would ask is about patching history. Have they done any patching therapy before? And if they have done, we have to mention for how long and which eye has been patched. And we can also ask what activities the child does during the patching, so that also we can know the compliance of the child with the patching. Together, we can also ask about the vision therapies the child is doing. Okay, so vision therapies the child is undergoing, and we should also mention which therapy and for how long. Suppose we should ask about ocular massages, because it's very common that the child is given ocular massages in cases of lacrimal system abnormalities. And we should ask about surgeries and lasers both. We should ask about squint surgeries, and we should ask about any early cataract surgeries. We should ask about the laser to rule out if the baby is a ROP baby. Moving on next to the medical history, apart from all the systemic conditions which we are asking them, we have to ask about the development of the child. Did the child walk properly? When did they attain the head control? When did they start crawling? That is what we have to ask about the motor skill development and other developments as well. And another important aspect of the medical history in kids is we have to ask about seizures. So not only congenital seizures, we have to ask about febrile seizures as well, if the child is getting any seizures during high fever. So it is recommended that we know the local word for seizures, because some parents will not understand the word seizures. So it's recommended that we know the local word. We should also ask about the supportive therapies, if the child is taking any supportive therapies like occupational therapies or physiotherapies or speech therapies. We should ask about that. And okay. The next very important factor is the family history, because we know that in kids, most of the conditions are genetic, like myopia is genetic, Leber's congenital amaurosis, as well as retinitis pigmentosa. So it's very important that we know if the parents are myopic, or the siblings are myopic, or if the siblings had any eye conditions, if the siblings underwent any eye surgery. So it's very important to document all this. Moving on next, usually we ask what ocular medication the patient is undergoing. For kids, it is recommended that we ask about the systemic medicines as well. This is because if a child has asthma and is using an asthma pump which has steroids in it, so we can explain the patient, the parents of the patient, that steroids have ocular manifestations. So if you can talk to your physician or pediatrician to have a substitute for this medicine, that it would be better. So it is good to always ask about the systemic medications which the child is using. We have to also mention the allergies, just we would do in any other normal patient. About the lab investigation, we should ask if they have done any brain scans before, or any sound scans before. Obviously, it would be uh, in get together with the complaints. If the child, if it's a small baby and they complain that the baby cannot even see the light, so it would be recommended that we have a brain scan, a MRI scan, a CT scan will help. We should also ask if they have done any ERGs or VEPs before, so it would help us to know the integrity of the visual system. So apart all this, we have to also mention that who has narrated the history. Is it the mother? Is it the father? It's very important to mention who is narrating the history. Okay, so this part is very important in a pediatric patient, and we would normally not ask in a regular patient the birth history. So there are 4 factors in the birth history. Let's see one by one. So the prenatal factors. The prenatal period is the period before delivery, so the entire pregnancy period. So here the mother's history is very important. We have to ask the mother if she had any infections, especially the torch infections. We all know what the torch is, the toxoplasmosis, other rubella, cytomegalovirus, and the herpes virus. So we have to ask specifically of this torch infections if the mother had any infections during the pregnancy, because they can be transferred to the baby. And we have to mention if the mother had any medications for this infection. Next, we have to ask the mother if she had any gestational diabetes, any gestational hypertension, gestational thyroid, and we have to mention on which month she got it and what medication she took. Next, moving to the perinatal factors. The perinatal factors is the period just immediately after delivery, the very short period immediately after um, delivery. So we have to ask about the gestational age here. When was the baby born? Was the baby full term or was the baby preterm? If the mother knows the number of weeks, then it is very recommended we note the number of weeks as well. Type of delivery, is the baby was the baby delivered normally? Was the mother went under cesarean or vacuum delivery or forceps delivery? We have to ask the type of delivery as well. We have to also ask about the birth asphyxia. Did the baby cry immediately after birth? Or and about the meconium stain. Like meconium stain is when the child would take in its own stool inside the womb and it gets a stain. So we have to ask about that as well. So hospitals usually score the baby with an APGAR score. So this is the APGAR score where A stands for activity, P is for pulse, G is for grimace, and A again is for appearance, and R for respiration. So how the baby is presenting immediately after delivery, based on that, they give the scores, and then they find the total scores for all the 5 criteria. So if the total point score lies from 0 to 3, then the baby needs immediate intervention. If the score lies from 4 to 6, then the baby needs to be kept under observation. And if the score is 7 and above, then the baby is normal and can be discharged. Okay. Next, we move into the postnatal factors. This is the period after birth, some period after the delivery, and till when the patient, at the age the patient is being presented to you. So we have to ask about any birth traumas. Like sometimes during cesarean, the umbilical cord gets stuck on the neck of the child, making it difficult for it to breathe later. So we have to ask about the birth trauma. We have to ask if the baby was kept in incubation, did receive any oxygen therapy or phototherapy for neonatal jaundice. If did the baby have any torch infections, we have to ask all that. And we have to also mention the duration for all the therapies that the baby went into. For oxygenation, maybe if the mother knows or the report is present, then we can write what levels of oxygens were used as well. Next, moving on to the development, those are the domains which we would be asking about the development. In gross motor, we would be asking about the head control, the crawling, the walking. Is it okay? Was it delayed? Next, in the fine motor, we will ask about the grip of the child. Have they attained to hold objects? Have they attained the pincer grip? And moving on next, the cognitive, that is like memories, visual perceptive is the Sorry, hello.
I think go ahead. It was somebody's mic. We turned it off. It's okay.
Okay. Okay. So in cognitive would be like the memory of the child, visual memories as well, visual perspectives. Moving on to the language, we would ask about speech. Is there any delayed speech in the baby? Did the baby go for any speech therapies? Sometimes during pregnancy, during delivery, the baby has the tongue attached to the upper part of the mouth. So we have to surgically cut it. So we have to ask about that as well. In social, we will ask how does the baby react to known faces? Does it smile? Does it make any cooing noise? Maybe how does the baby react to unknown places? So that would be what we would be asking in social. And growth would be the physical maturation of the baby. So moving on next to the step-by-step evaluation. So this is the step-by-step evaluation which I would recommend. We start with the sensory evaluation, then moving on to the vision assessment and refraction. Next we go on to the motor evaluation, and finally we would check the ocular health of the child. So why am I saying that we have to do the sensory evaluation first? This is because when the patient enters our room, the eyes are in fusion position, and we have not yet dissociated the eye by doing, like, for closing the eye for vision assessment or doing cover test. We have not yet dissociated the eye. So it is better to do the sensory evaluation when the eye is in fusion position. We will be seeing each one by one. So moving on to the sensory evaluation, there are two aspects of it: the stereopsis and the fusion. So these are the most common charts we would be using for the testing of stereopsis. As we know, that is the Titmus fly test and the Randolph test. So the Titmus fly test gives us the local stereopsis because it has some monocular cues, while the Randolph gives us the global stereopsis because the chances of monocular cues are very less there. And we have to do this at least 40 centimeters. Okay. Moving on next to the fusion, we do it with the WFDT. I hope everyone is very well known to the WFDT test. So we do it both at distance 6 meters and at near 33 centimeters. So depending on what the patient is responding and how the red and green glasses are placed, we have the responses. We can have a fusion, we can have a right or left suppression, and we can have diplopia. So based on how the red and green dots are placed, it can be either uncrossed or crossed. Okay. So moving to the vision assessment, so each age group has a different way how we can assess their vision. We will be seeing each age group and how we can assess the vision. So starting with the neonates, how would we start taking the assessment? First, we have to check about the meanness reflex. So the meanness reflex is how the baby is responding to an oncoming object, or an object which is coming towards the face. Is it blinking? Is it turning their face? So we have to mention how the meanness reflex is, or we can just write meanness reflex present. Then we have to check for media clarity. We can do that with a simple torchlight or with our retinoscope as well. Then we have to check about the pupillary reaction. We have to just check if the pupils are reacting to light or not. Next, moving to the infant group, we have to check if the patient is fixating to light and following it both horizontally and vertically. Then we can record the vision using the CSM method, which is central, steady, and maintained method. I will be showing you how it is done in the next slide. Next, we can use the preferential looking test, which is based on the preferential looking principle, where the child prefers to look at a pattern or a picture rather than a blank page. So I have a small video for you guys on where we are seeing how Cardiff visual acuity is done. So I want you to see how the child is pointing to the object. appreciate and acknowledge the child that they are doing really well. We can clap, we can tell them very good. Okay. For this child, I want you to see how the eye movement is. I know the video is disrupting, but maybe if you can see how the eye movement is according to the images on the chart. So moving on next to the toddler group, again, as some of the vision assessment may overlap with the groups, so it's okay. We can use the preferential looking test and the central steady maintained method for this toddlers group as well. Apart from the Cardiff Equity, we have other preferential looking tests. This is the LIA paddles. It has the grating equity on the handles. We have the teller equity cards. They have the Snellen equivalent and also the grating equity written on the back side of the card. Okay. And then we can also use LIA symbols. We can give a small card to the child and then the examiner can point at the distance chart and the child can point at the same shape on the card which has been given. So this is the LIA symbol chart with the matching card for the child. So we can do LIA matching for this age group as well. Okay, so let's move on. I will show you how we can do the CSM method. So when we shine a torchlight and see the corneal reflexes in on the baby's eyes, okay, and then we cover one eye. And suppose this is what happens under cover. Okay, the eye is moving out. So when we remove the cover, the eye will move from out to in and gain fixation again. Okay. So for this, we will write for the right eye because for the left eye, because we occluded the left eye. The left eye, the vision is central. It is steady and it is maintained because the child is maintaining fixation after the cover has been removed. So suppose if the child is not maintaining the fixation, the eye is still remaining outward after we remove the cover, so then we will write central, steady and unmaintained. So if the child has a nystagmus, then we will write central, unsteady, maintained or unmaintained depending on how the eye is taking fixation. Suppose if the child is not immediately taking fixation but blinks and then takes fixation, then we have to write central, steady, unmaintained, maintains fixation after blink. So that is how the documentation of the CSM method would be. Moving on next to the preschooler age group, we can use the LIA symbols again, but this time they would be saying out the names of the shapes. We can use a HOTV matching card. So this is the LIA symbol chart, which we have seen already. And this is the HOTV chart with a matching card. Okay. Then we can use the normal tumbling E method in this group. Okay. Moving on next to the school-going group. So these children are elderly enough. We can rely on what they are saying and their responses. So we can just check their vision with the normal Snellen chart and the logmark chart. So the most important part of the entire examination would be the refraction for kids. For younger kids, like in the neonates, the infants, the toddlers, and the preschoolers, obviously we cannot rely on what subjective response they are giving. So we have to depend on the objective refraction entirely. And if we are finding any high cylinders, then it is recommended that we take a keratometry finding as well. If it's not possible to make the child sit on an air, Then we have the handheld keratometry as well, so we can do that as well. And for the elderly children, we can rely on their responses. So we have to do the objective, we have to do the subjective. Again, wherever necessary, do the keratometry, and if required, take the AR readings in recording as well. But we have to do the retinoscopy in child because it is very helpful. Irrelative of what their age is, we have to do a dilated refraction. A cycloplegic refraction is recommended in all the age groups. And for elderly children, if we suspect any spasms or we suspect any change in refraction, very frequent change in refraction, especially minus powers, then it's recommended that we also do a dilated subjective refraction. Okay, it will give us the exact amount of refractive error the child has. Moving on next to the motor assessments. So these are the aspects which are covered in the motor assessment, starting with the most common Hirschberg test. So we use the corneal reflex to see if the eyes are aligned or misaligned. So based on how the corneal reflex is either nasal, temporal, up or down, we can comment on what deviation the child is having. And then we can move on and do our cover test for both distance and near. So let me just show you a small video again on how we can improvise with kids for the normal cover test. So we can see that examiner is adjusting the child so that he is at eye level at the target given. And then the target could be anything. You can just improvise it. You can also use a moving target, and then just do the normal cover test, and then make sure that the child is looking at the target, and then find your assessment, do your assessment. Okay. So we do that for near as well. Use any attractive target which will grab the attention of the child, and do the cover test. After we have done the cover test, then we can move on to do the PBCT and find the quantitative amount of the squint. Okay. Moving next, this next part which I'm going to tell you is the MIM. This is the muscle imbalance measure, which we don't do it regularly in our OPDs. But if we suspect aphoria and we cannot find it on a cover test, then it is recommended that we can do it. So this is the MIM card which we have, which is based on the Prentice's rule. And okay, we can do this for both distance and near. So basically, a light is shined from the backside of the card into the center, and we place a Maddox rod on the eye of the patient, and the Maddox rod will turn this yellow light into a streak, and then we ask the patient where he or she can see the streak. And if the patient says that the streak is aligned with the yellow light, then there is no phoria present. However, if the patient says that the red streak is at the right side or the left side or up or down, based on what number it is, that is the amount of phoria which we will be noting. So for example, here, if the patient is saying that I can see the red streak at number 4 on the right side, so we will mention that 4 prism diopters of esophoria. Okay. Moving on next to the EOM, so we have to check about the integrity of the extraocular muscles. So we will use the broad H method and move from how I have shown it in the image from 1 to 2 till 9 and test all the extraocular muscles. So for kids, for babies or very small kids, it is not possible that we tell them to follow the broad H test every time. So we can use the doll's eye phenomena, where the eye moves against the head movement. So we can use the doll's eye phenomena to check the integrity of the extraocular muscles in smaller kids. Moving on next to the pupillary examination, we have to check if the pupils are reacting and if any RAPD is present. So how do we do the RAPD test? That is, there is a small video. Okay, finally, then we will move on to the ocular health. We will do a slit lamp examination where if the child is able to sit on a slit lamp, then we will do the slit lamp examination. We can do the IOP test in different ways. In smaller kids, we can just have a gross idea of the IOP using the digital method and comment on what finger tension we are feeling. If in cases of congenital glaucoma post cataract surgery, it is very important to quantify the IOP. So we can use a handheld Perkins and or we can do a Goldman applanation tonometer. For elderly children, just do a Goldman applanation tonometer at the regular checkup as well. Then since we are dilating the patient with the cycloplegic, then it's no harm doing the fundus examination as well. Okay, so these are the visual milestones I have tabled up, which we need to take into consideration. The slides will be available, so you can just go through later on what the visual milestones are. Okay, moving on to the clinical pearls. This is what I have learned from my seniors as well, and I keep it in mind still. So each child is different. We have to learn to improvise in all our tests. Next, we have to allow the child to read the vision charts in any abnormal head posture the child is comfortable in. We do not have to keep on telling the child, keep your head straight, keep your head straight. Just allow the child to read with the AHP, just making sure that the other eye is covered up well. Next, we have to always remember to mention if the child is peeping over the RX. This will give us an idea if the child is undercorrected, overcorrected, or is not preferring the glasses. So we have to remember to mention that, and always recheck the vision in different charts, because the children are, they have a very amazing brain and they can just remember all the charts because they are coming again and again to you, so they'll just remember every chart. So it's recommended just recheck the vision with different charts as well. So talking about everything, we know what our expectations are, that, and so let's see what our expectations are and what the reality is. So this is what we expect, that the child will be very cooperative for all the tests. And this is what we experience, a very uncooperative child who would just not let us do any examination. So ending it up, I would like to give a very big thank you to the entire team at Shankar Nethralaya, especially the pediatric department, which has given me all the knowledge which I have right now in the pediatric group. And a very big thank you to the online Optom Learning Series for giving us a platform to just share what knowledge we have and to for just giving us the platform to present. Thank you very much.
Thank you very much for your very detailed and insightful ideas, what you have shared in terms of, approaching a pediatric patient in terms of eye examination. We do have a couple of questions, and so the first question here is, what is the significance of performing the word for dot at near?
Okay. So usually we do the FDT for distance in a normal regular OPD, and we wouldn't do it for a near one. So we want to know the depth of suppression, how deep the suppression is, and how much intensity of the suppression is. So usually for amblyopic patients, we would also do the WFDT in normal light and under dark illumination as well. We know that for the normal regular OPD, we would just turn off our lights and do the WFDT. But for the density of the suppression, we do it both in the light conditions as well as in dark conditions. And for the intensity, how intense the suppression is it like the amount of suppression, the area of suppression, then we can do for distance, because the distance will give a more broader aspect of the retina and how it is suppressed. If maybe in a like large basis, the child may not suppress their eye, but if for smaller areas, maybe the retina is affected on a very small part, then they can be suppressed for near as well. So it is very important to know how intense the suppression is. That is why we do it for near as well.
Okay, and usually it is very difficult to assess motor evaluation in children below 2 years. So do you have any tips on how do we do that for younger kids below 2 years?
Okay, the motor assessment for kids, first we would be relying, if they are not at all cooperating for a cover test, then just rely on the Hirschberg test and do a modified Krimsky to find the amount of squint they are having. That would be very reliable. But just give them a very attractive target for near, give them to see a video. We just want the child to look at something, so give them a video also, even cartoons on the phone. Maybe you have a LED screen back and then play some video. Just improvise and give them a target which they would attractively look at, and just do the cover test really quick. So just get a gross idea, and then that will be okay.
Yeah. And how often do you perform Mohindra retinoscopy in kids?
So Mohindra for near is near retinoscopy, or even the dynamic retinoscopy. So we usually do it when we are suspecting any spasm in the kid, or we suspect that maybe there are some accommodative issues in the kid. Then that time we would recommend doing the near retinoscopy. But usually we are actually giving a near target, because it's very difficult for us to keep on making the very small child keep on looking at distance. So usually what I used to do in my fellowship times, and which I do right now also, I give a target at least 1 meter or 2 meter. So with knowing the proximity, it is we are always just doing the near vision. So it is very recommended that we write at what distance the target was given, like did retinoscopy using a target at 1 meter or 2 meters.
Yeah, and also when you cannot do cycloplegic, I think Mohindra will help you a lot, because some practices, like, you're working in an optical retail outlet where you probably cannot use a cycloplegic. Some countries, there is a ethical issue of using drugs as well in your private practices. So Mohindra would help a lot in terms of determining as well as knowing the amount of refractive status of the eye. Any idea about the book retinoscopy, somebody has asked, on regular basis? Do you also perform book retinoscopy?
Okay, so book retinoscopy is when you give different reading material, the sizes of the reading material to the child on the plane. It's just like how we do the dynamic retinoscopy, but in dynamic retinoscopy, we are putting in the plus. And with book retinoscopy, first we will check the reflex with the comfortable reading size that the child is reading very smoothly. Then we would go to the size which is like N6. Maybe the child is reading a N6 and is comfortable to read that. It's the normal reading size which they use regularly. And then we go to a more smaller size where they have to intensely look and then do the retinoscopy. So all those three sizes, they give different reflexes. We don't do it in regular basis, but again, if we suspect that the child is having difficulty in reading the size which is at school, then we can see how the eye is working with that particular size, and then we can do it. It is basically based on what the complaint of the child is.
Yeah, that's right. And can you explain more about the visual milestone? I think you put it up on some slides about visual milestone. So,
Okay.
is there anything? Uh,
So these are the visual milestones, the one which you're seeing right now. This is like the child should have attained the particular visual milestone by the age. So I have put up the table. Because of time, I didn't read out the table. So the table will be available anytime. I have put up my email address on the first slide as well. So anyone who wants to get the visual milestones, I can mail them to them.
Yeah, that's right. So this is just this is what the normal milestone with a kid should have. So you need to look for all this. When you have a kid of 3 months old, you must make sure that he reaches to the objects and fix it to the pattern. So these are just guidelines where the normal kid should have. So you must have an idea about this table. So thank you for putting up this table. You can have it in your clinics pasted up on your wall, and then you can remember that. You don't need to memorize it. Okay, one
Mhm.
last question. Can you elaborate on how the type of birth affects the development of the eye? The birth
Type of
delivery.
delivery, type
Yeah,
of delivery.
yeah,
Okay, so for a normal delivery, there would be no problems. Uh, that we could just recommend document it. It's a normal delivery. For cesarean, as I said, that sometimes there's a chance that the umbilical cord gets stuck into the neck. So we can ask about that if it's a cesarean. Next, about what we can have vacuum delivery. So in vacuum delivery, they put a vacuum on the head of the baby and then pull it out. So that can cause microcephaly in the child, causing also microcorneas and micro ophthalmia. So that is one thing which we have to take into consideration. So a baby with microcephaly, we can just ask the mother, was the delivery done by vacuum? And then the forceps delivery, we all know, because the forceps is placed over here, then we can have a lateral rectus palsy. So it's very important to know the type of delivery as well.
yeah, because the baby's head is too fragile, so we want to make sure that it didn't interfere with any of the ocular structures for that matter. That's right. And one last question. Let's take this. Can you explain once again on the Apgar score? I think it's also on the slide, but I think they might have missed it. The Apgar score of the visual.
Okay.
Uh,
Okay, no problem. I'll just explain it to you once again if time allows. Is that okay?
yeah, I think we'll take one last question. Yeah, this is the last one, and we.
Okay. So this is for the Apgar score. So this is the activity. Like, how is the activity of the child? Is the child okay? So how active is the child? If there is no movement at all, if the child is not moving at all, then they will give you the child a 0 point. If the limbs are very flexed, is very like loose and not moving properly, but still some movement is there, then they would give a 1 point. And if the child is very active, then they will give a 2 points. So basically, that is how they will give the point system, and based on the 5 criteria. Then for each criteria, they will give a score. So for example, I have a baby and for activity they have been given 2. For the pulse it's given a 1. For the grimace it's given a 1. For appearance it's given 2, and respiration it's given 1. So the total would be 7. So that way, if the total points is from 0 to 3, then the baby needs immediate intervention. Maybe it needs to go under surgery or needs to have oxygen therapy. So immediate intervention with the physician is necessary.
Yeah.
So if the score is between 4 to 6, then the baby can be kept under observation till it gets into the normal stages. And if the score is 7 and above, then the baby is normal and we can just discharge the baby from the hospital.
Okay, thank you. Thank you so much for your time. Again, before we leave for today, just let me share my screen and let's see what we have tomorrow. So tomorrow we are going to have a talk about progressive lenses, so dispensing tomorrow. So we will have Optom Mumtaz Kazi. She's an assistant professor at Lotus College, India. And she is going to talk to us about the progressive additional lenses and a bit of troubleshooting and the recent advancements on them. So tune in tomorrow. The timings are mentioned. It's 4 p.m. in the afternoon India time and 6:30 evening p.m. in the Malaysian time. So tune in tomorrow. I hope to see you all tomorrow again. Until then, stay home, stay safe, and bye for now.